Good morning, everyone. The topic of today's group discussion is time to retire haloperidol. My moderator is Dr. Shobhit Garg, sir. Introduction. DSM-5 defines agitation as an excessive motor activity associated with a feeling of inner tension. It is non-productive and repetitious and consists of behaviors like pacing, fidgeting, wringing of hands, pulling of clothes, and inability to sit still. A progression in the severity of agitation can lead to aggressive and violent behaviors. Etiology. The three major categories: psychiatric manifestation of general medical conditions, example encephalitis, meningitis, encephalopathy, metabolic abnormalities, thyroid disease, and seizures, post-ictal state. Second is substance intoxication or withdrawal, like alcohol withdrawal, delirium. And third, primary psychiatric illness like schizophrenia, bipolar disorder, dementia, personality disorder, and autism spectrum disorders. History. Prior to the development of antipsychotic medications, pharmacological treatment of agitation include insulin coma therapy, barbiturates, bromides, and various anesthesia cocktails. In 1951, chlorpromazine was discovered as a go-to drug to achieve rapid tranquilization of psychiatric agitation. In 1970, haloperidol emerged as the first-line option to manage agitation due to availability of its IM and IV preparation, as well as relative lack of side effect compared to low-potency chlorpromazine. Haloperidol. It is the most common first-generation antipsychotic currently used to treat acute agitation. It belongs to butyraphenol class. It is a highly potent and selective antagonist for dopamine D2 receptors. It is FDA approved for oral and intramuscular use for the treatment of agitation in acute settings. So via IM route, the onset of action is within 30 to 60 minutes. Elimination half-life is 12 to 36 hours, and the duration of effect is for 24 hours. Side effects, extrapyramidal side effects. Various studies have found that overall the rate of extrapyramidal side effects was as high as 20% after treatment with haloperidol. Parkinsonism occurring in up to 17% of the patient, dystonia in up to 11% of the patients, and akathisia in up to 10% of the patients. In a study, it was found that EPS symptoms occurred in 20% of the agitated patient treated with haloperidol alone, but only in 6% of the patient treated with combination of haloperidol and lorazepam. Other studies have found that adding promethazine to haloperidol can similarly reduce the incidence of extrapyramidal side effects. Because of these studies, haloperidol is frequently administered in combination with another medication such as lorazepam, promethazine, and diphenhydramine. Because of using multiple medications to control agitation may increase the risk of both oversedation and interaction with other medications. The next side effect is QT prolongation. Haloperidol prolong QT by blocking the repolarizing potassium channels. The risk factors are a pre-existing heart condition, a QTc of more than 450, electrolyte imbalances like hypokalemia and hypomagnesemia, concomitant pro-arrhythmic drug use, and conditions that can predispose to torsades de pointes or QT prolongation, example hypothyroidism. Haloperidol label warning indicates that high doses and intravenous administration of haloperidol appear to be associated with higher risk of QT prolongation and torsades de pointes. In a systematic review done by Kali Mermeseti, the FDA extended warning for intravenous haloperidol and torsades de pointes. How should the institution respond? Have concluded that haloperidol, whether administered orally IM, are poor choice for the patient with agitation who are at the risk of arrhythmia, including those with relevant medical comorbid conditions or delirium. Less than 2 milligram IV haloperidol can be given without concurrent ECG monitoring in a non-critical care settings in patient without risk of QT prolongation or torsades de pointes. And more than 2 milligram IV haloperidol should be given after ECG monitoring and in patients without additional risk factors. An updated 2017 Cochrane review of haloperidol psychosis-induced agitation aggression concluded that haloperidol is effective intervention, although the evidences are weak. Significant treatment effect may take as long as 1 to 2 hours following multiple IM injection. Treatment with haloperidol carries a significant risk of EPS, and combination of haloperidol and promethazine was more effective than haloperidol alone. Then what are the alternatives we have to manage the agitated patient? Graded approach. Four approach management is proposed for to manage an agitated patient. Environmental manipulation, de-escalation technique, physical, mechanical restraint or seclusion, and last is pharmacological interventions. First is modification of environment. Modification of environment include assuring that the patient is physically comfortable, minimizing the waiting time, decreasing sensorial stimulation by decreasing the external stimuli by making the patient sit in a quiet room or an individual examination room, removing all the potential dangerous objects away from the patient, and communicating a safe, respectful, and a caring attitude towards the patient. Second is de-escalation. De-escalation is the use of technique, verbal or non-verbal communication skills aimed at calming the agitated patient and to gain his or her cooperation in evaluation and treatment of agitation. The 10 principles of de-escalation are: respect the personal space of the patient, stand at least 2 arms away from the patient, do not be provocative, establish verbal contact, be concise, identify the wants and feelings of the patient, listen closely to what the patient is saying, agree or agree to disagree, lay down the law and set a clear limit, offer choices, and debrief the patient and staff. Then is restraint and seclusion. What is seclusion? It is an involuntary confinement of a patient alone in a room from which the patient is physically prevented from leaving. And a restraint is any manual method, physical or mechanical, that immobilize or reduce the ability of the patient to move his or her arm, leg, body, head free. Within 1 hour of the seclusion or restraint, the patient should be evaluated face-to-face again. Both restraints have a short-term and long-term detrimental implications on patient and physician-patient relationship. Because of this, regulatory agencies are pushing for reduction in the use of restraint. Restraint or seclusion should only be imposed to ensure immediate physical safety of the patient, staff members of the other. The last are pharmacological method. If the behavior of the patient is extreme or continue to deteriorate despite other management efforts, medications must be offered. Ideal pharmacotherapy for agitation should be that the pharmacological agent should be easy to administer, non-traumatic, provide rapid tranquilization without excessive sedation, have fast onset and sufficient duration of action, and have low adverse effect and drug interactions. So what is the goal of pharmacotherapy? Rapid tranquilization. Rapid tranquilization means it is a calming process separate from total sleep induction, allows the patient to participate in care, and enables clinician to get the history, initiate a workup, and begin treatment of the unidentified conditions. First are benzodiazepines. Benzodiazepine facilitate GABA neurotransmission, which is an inhibitory neurotransmitter in brain, which is this action responsible for rapid tranquilization. The pros of using benzodiazepines are that studies have found that benzodiazepines are an efficacious antipsychotic with less extrapyramidal side effects and less cardiac side effects and better sedation than haloperidol. And what are the cons of using benzodiazepine? Sedation and respiratory depression. When used parenterally in patients with underlying respiratory conditions or combination with CNS depressants such as alcohol. First benzodiazepine is lorazepam. That is the only benzodiazepine with complete and rapid IM absorption. On IM or sublingual administration, in 60 to 90 minutes, it attains a peak plasma concentration. Total duration of effect is 10 hours, 8 to 10 hours, and elimination half-life is 12 to 15 hours. Some studies have shown that lorazepam has equal efficacy to haloperidol in treatment of psychotic and manic agitation, and some studies even indicate superiority. Lorazepam has better tolerance and less aversion to repeat dose administration, but it should be used with caution in patients with alcohol, barbiturate, opioid intoxication because of the additive effect of sedation. A 2005 expert consensus panel for behavioral emergencies recommended the use of lorazepam alone over haloperidol for agitation in patients who have stimulant intoxication, personality disorder, comorbid obesity, cardiac arrhythmias, a history of akathisia or EPS, a history of amenorrhea or galactorrhea, and a history of seizure. The other benzodiazepines that can be used is midazolam, which cause rapid sedation, which is better than either haloperidol or lorazepam, but it has a FDA black box warning of respiratory depression associated with IV administration. Atypical antipsychotics, they have broader spectrum of response. They have a different side effect profile. They have less EPS, less akathisia. Still the QTC concerns remain, and they have metabolic syndrome. No randomized controlled studies have examined the use of medications in population, examined the use of atypical antipsychotics in population with severe agitation, drug-induced agitation, or a patient with significant medical comorbidity. The second generation, in all the studies, the second generation antipsychotics have been shown to be at least as effective as haloperidol for the treatment of acute agitation. In an RCT comparing IM ziprasidone with haloperidol found equivalently modest effect on QT prolongation. There have been no published controlled trials on second generation antipsychotics combined with benzodiazepines. In a systematic review done by Pawnee MJ and colleagues on haloperidol for psychosis-induced aggression or agitation, it was found that olanzapine is more sedating than haloperidol, so no need of multiple injections. Olanzapine was better in controlling agitation, as effective as haloperidol in reduction of both aggression and hostility, and it has less side effect profile than haloperidol. However, olanzapine comes with a black box warning. Marder et al. Describes a number of adverse events in the patient who are administered a combination of olanzapine and benzodiazepine. So, FDA has issued a black box warning regarding the use of olanzapine and benzodiazepine together, which can cause fatal respiratory depression. A newer variant, dexmedetomidine. It is an alpha-2 adrenergic receptor agonist. It was available since 1999 as an IV formulation indicated for sedation prior to surgical procedure. Dexmedetomidine sublingual film, Iglami approved by FDA on 5 April 2022 after two phase 3 randomized sham control trials, Serenity 1 and Serenity 2. It is indicated for it is available in two forms, concentration 120 micrograms and 180 micrograms, and it is indicated in adult for acute management of agitation associated with schizophrenia and bipolar disorder. Next is loxapine. It is a first generation antipsychotic belonging to dibenzoxazepines. It is structurally related to clozapine. In 2012, it was FDA approved as an inhalatory route for acute treatment of agitation associated with schizophrenia and bipolar disorders. So, what are the advantages of inhaled loxapine? Rapid onset of anti-agitation effect. It has less invasive and needle-free systematic delivery of drugs, no hepatic first-pass metabolism, and no apparent QT prolongation. The disadvantages being because the administration is handheld and single doses disposable, breathe accurate tools, so patient collaboration is required. It is contraindicated in patients with asthma, COPD, lung disease associated with bronchospasm, and with patients with acute respiratory symptoms or signs such as wheezing. And it is not approved for treatment with dementia-related psychosis. Next is naltrexone. Typical behavioral abnormalities including hyperactivity, short attention span, impulsivity, aggressiveness, and temper tantrums, self-injurious behavior such as head banging and biting is common in autistic disorders. 3 case reports, 8 case series, and 14 clinical studies have found out naltrexone to be effective in decreasing self-injurious behavior. On a dose as low as 0.5 milligram per kg, response was seen as early as 7 hours. Adverse effect being bitter taste and sedation. In a study published in Sage Journal in 2016 on efficacy and safety of naltrexone use in pediatric patients with autistic disorder, have concluded that naltrexone treatment may be attempted in a child with autism disorder, starting with a low dose such as 0.5 milligram per kg daily, and titrating upward according to response and adverse effects. Next is ketamine. Various observational studies support ketamine's efficacy when administered IV or IM route in psychiatric emergency. Adverse effects being dissociation, psychotic exacerbation, and respiratory depression. However, there are not many randomized controlled trials available to recommend parenteral ketamine for psychiatric agitation. Next is combination therapy. Combination therapy, the most common combination therapy that we are using is haloperidol plus lorazepam. So combination therapy in individual medications can be targeted to different components of agitations like anxiety and arousal and psychosis. The benefit is faster reduction in agitation, less injections required, simple to administer, and lower incidence of extrapyramidal symptoms. The side effect profile of both benzodiazepines and antipsychotics may apply, and excessive sedation is the most common adverse. Now, the protocol for treatment of agitation. First of all, we have to identify the cause of agitation. If the agitation is associated with delirium, and the cause of delirium is either alcohol or any benzodiazepine withdrawal, then you have to replace it with oral. First option is to replace it with oral benzodiazepines. Oral benzodiazepines, lorazepam in a dose of 1 to 2 milligram, chlordiazepoxide 50 milligram, and diazepam in the dose of 5 to 10 milligrams. And then the second line is parenteral benzodiazepines, lorazepam 1 to 2 milligram IM or IV. If the delirium is not due to alcohol or any benzodiazepine withdrawal, then first you have to identify and correct the underlying medical conditions. In such case, we have to avoid benzodiazepines. First line option in such cases, oral second generation antipsychotics like risperidone or olanzapine. Then oral first generation antipsychotics, haloperidol. Then parenteral second generation antipsychotics, and olanzapine 10 milligram IM or ziprasidone 10 to 20 milligram IM, and then parenteral first generation antipsychotics, haloperidol. If agitation is due to intoxication, is either due to CNS stimulants, then again we have to treat the delirium by oral benzodiazepines, lorazepam 1 to 2 milligram, chlordiazepoxide 50 milligram, and diazepam 5 to 10 milligrams. And then second line option is parenteral benzodiazepines. If the agitation is due to intoxication, due to alcohol intoxication, then again avoid benzodiazepines because of the risk of excessive sedation. Now, if the agitation is associated with psychosis in a patient with a known psychotic disorder, then the first line option will be oral second generation antipsychotics, risperidone and olanzapine, then oral first generation antipsychotics, haloperidol, and then parenteral second generation antipsychotics. So oral antipsychotics should be tried before trying for IM or IV formulations. Next is post-traumatic brain injury and agitation. So agitation has been reported in 20 to 41% of the patient during an early stage of recovery. A state of confusion that follows the initial injury and is characterized by disruptive behaviors like restlessness, confusion, physical and verbal aggression, impulsivity, perceptual disturbances, and inattention. An article published in a neurological journal, Agitation After Traumatic Brain Injury, a review of current and future concept and diagnosis management by Gary L. Hoover and colleagues, have suggested a multimodal approach to manage a post-traumatic agitation. in which first you have to treat the contributing factors like pain, infection, or urinary retention. Then you have to modify the environment, then employ behavioral approaches, and last is the pharmacological management. And they have proposed the use of concluded that propranolol has the highest level of evidence supporting in use in management of post-traumatic agitation. They have proposed the use of propranolol 60 to 420 milligram per day in 6 to 8 divided doses for the treatment of agitation, post-traumatic agitation after brain injury. The contraindications are COPD, AD blocks, heart failures, and severe bradycardias. And the adverse effect are bradycardia, bronchospasm, hypotension, sleep disturbances, and sexual dysfunction. The second line options will be second generation antipsychotics like quetiapine and ziprasidone. Methylphenidate, valproic acid, and carbamazepine may offer some benefits, but further studies are needed in this. So coming to conclusion, for the management of acute agitation, graded intervention, that is non-pharmacological intervention, then voluntary or oral medications, and then voluntary IM medications when necessary. The use of medical restraint should be discouraged as much as possible. Medication should calm an agitated patient rapidly without excess or prolonged sedation. A patient should be involved in the process of selecting medications to whatever extent possible. Example, if the patient wants to take an oral or an intramuscular medication, if the patient is able to cooperate with taking oral medication, these are preferred over the intramuscular medications. And haloperidol has higher risk of adverse effect related to the newer alternatives, which suggests that its use should be discouraged. It should no longer be considered for the first line interventions. This is a table. This is a table depicting the first line interventions along with the level of evidence that we have for the first line medications recommended for agitation are aripiprazole of IM formulation, and the level of evidence is 2. The highest level of evidence that we have is 4. Lorazepam IM route, loxapine inhaled route, and olanzapine IM. In a dose of 2.5 milligram, and maximum we can go up to 10 milligrams. The second line medications that are available is asenapine sublingual formulations, haloperidol IM formulations, single dose of 5 milligram, and we can go up to 15 milligram. Haloperidol plus midazolam, single dose of 2.5 milligram haloperidol and 7.5 milligram midazolam. Risperidone in a oral formulations, 2 milligram, single dose of 2 milligram and a maximum dose of 4 milligram. And the third line interventions are haloperidol oral, loxapine IM, quetiapine oral, and risperidone oral. These are my references.
Okay. So this one, Suna. So I will read. She has explained from the definition of education, and she has actually explained in context of education, in emergency after the escalation of various pharmacological last table she has shown is kind of but as they say that orally and character has similar efficacy, but so after method of the institution that the efficacy is same. Time questions, comments. Important is definition of was asked in the last exam. This article came across to me in one of the psychiatrist groups, so I thought that let us study this. So we asked that we present this and also because all we all deal with education. We all get calls from ICU because of education. The hyperactive Indian first of all, FDA is not approved IT for कोई सा भी option hello तो आई Haloperidol देती है और साथ में तो मुझे पता नहीं कि आई तो मेरा जन आई है कि once it is finished with there here from और क्या हमारे यहाँ कौन से कॉन्टेक्स्ट में delirium agitation what we agitation है antipsychotic in context of delirium classification. So antipsychotics have delirium antipsychotics in many ways have more therapeutic सर ने कि आप कोई परमानेंट एडवाइस लिख के आ रहे आप कह सकते हैं कि ये समझिए आप इंग्लिश कलम पे एजुकेशन नहीं है तो पहले टेक्निक का ऑप्शन है और पता very important point which he shared and allow those patients to make psychotic patient, dedicated patient, marker, treating, escalate. These those patients should then imaging. Very not work up, detail work up to anything with them. Take care for our question. Acute dedicated patient. पहले था two confusion and these two. What about question when you will so yeah, education. Let's look at that. Education withdrawal suspected. उसमें only when the resistance is corrected. तो जहाँ आपको intoxication लग रहा है तो वहाँ पर आप antipsychotic वहाँ पे आपको intoxication लग रहा है agitation में intoxication patient intoxicated way में आया है PTOS is alcohol right तो अगर alcohol intoxication में आया तो आप benzodiazepine नहीं देंगे और depression में चले जाएगा ना agitation का antipsychotic एक बार होता है patient intoxicated होकर चिल्ला रहा होता है important then first line अब जो लास्ट में कैन में दिखाया है EAP गाइडलाइंस अगर आपने पढ़ी article says the haloperidol has become because of need to do an ECG. ECG monitoring important. Monitoring में और important क्या है? आपने haloperidol दे दिया उसके बाद ECG कराने का कोई फायदा नहीं। आपको दूसरा ECG करना है। That is baseline ECG में आप compare कर सकते हैं कितना किसी बढ़ा baseline से उसकी किसी बड़ी हो सकती है that is why because of this problem onion very because of हमारे इंडिया में onion मिला I think last year used to be there उसके साथ एक problem है injection चापन injection को कम करना you can't give it the logarithm within 1 hour you have to space out 60 minutes के बाद आपको logarithm see the risk of social drop का भी risk रहता है आप यहाँ पे logarithm भी यूज करते हैं मतलब कोई इशू नहीं then
patient
what is the cost of development?
trying to shift it from the long acting.
But haloperidol injection of the but sedation with olanzapine is not very good. You need to select patient when you put it injection. So whatever we are doing in our context is तो सारे आईसीयू रेफरेंस में आते हैं तो talk to anesthesia guys they used to do that they in the anesthesia surgical procedures with different education but ये तो अभी है नहीं नहीं so if patient is in peri-operation process or your qualification then you have best medical card those बढ़ा दीजिए utilize it proof presentation and you said that it's okay एक पक्ष में कितना मिलेगा जरूरी होता है हर किसी बॉडी में वन पक्ष would not deliver prior to surgery दूसरे पक्ष देने पड़ेंगे आपको so आप जो एडमिट पेशेंट है उसका मास्क लगा दो उसके नोजल में उसके
so I think it does a lot seizures
मार्केटेड की इंटरनेशनल लगा तो आई थिंक आप या आपको जरूरत नहीं इंटरनेशनल मोर इजी तो वी कैन ऑलवेज आई डोंट नो आप यहाँ पे देख सकते हैं बट आपको डोज टाइप ऐसे में आप देखें आपको इसीलिए मार्केट में रेगुलर रहती है जब कहेंगे आप देने से पहले उनकी बात में लेवल ऑफ फॉर्मेशन चेंज हो because what will happen any cardiac event they will put it under a complication not because of any cardiac post heading to this is आपको कॉल आपकी Right? The problem with head injury is if you go for all these antipsychotics, it might get stabilized, even make them more the role of propranolol. Generally, you will find them with the pressure. So propranolol is advised. Propranolol is a very robust evidence in post head injury. That is why I asked the people. हमारे पास education में अच्छी बात है. So they are adults. You would treat them as adults. The problem is when the emotions speech up. Then what are the she shared because I asked her. Recommendations will come later on. Tackle education, mental addiction, behavioral problems, and disorders. These are the only naltrexone off-label found it to be effective. और off-label आप लोगों ने यहाँ पे haloperidol वो भी सब दिया है. ये level of evidence ये क्या है? You said that the highest level is 4. Highest level means highest level of evidence. So lowest level of evidence is 4. Highest level of evidence is 1. अंदर में वो 4 है, but lowest still 5. The level of evidence is अब वही आर्टिकल के शुरू में दी जाती है. ये मान लो मेटा एनालिसिस है तो लेवल 1 है ना, आरसीटी में लेवल 2 है, केस रिपोर्ट्स में लेवल 4 है, कंसल्ट द एक्सपर्ट ओपिनियन में लेवल 4 है. ओके पर इंडिया में Catatonia में they have thought out बच्चों में elderly अगर आप visualization pattern देते हैं तो paradoxical education was that is why syrup is better resolution will be syrup is का क्या फायदा है. Public service because tablet is all time not happening like that, and some amount is also absorbed from oral. It goes very fast. So that at times because आपने सिर्फ से tablet में दिया है तो कुछ नहीं होगा. Alcohol induced withdrawal with education we found sites from but I think guidance and I can roll in alcohol withdrawal guidance. BPST the black box one. So then we give there is actually no approved. So you have to do all those behavioral techniques. Now trying this. How important is PTSD? You need to take for the agents after 4 years. YouTube पे आप दे रहे हैं आपको उसको पेपर करने में कुछ 4 months में करना है. अच्छा
We can stop with Rajapan. Antipsychotics.
सोशल एजुकेशन हो गया है फिर क्या करें दूसरा बंद तो नहीं पड़ेगा तो सही है अच्छा नहीं बोल रहे दे रहे हैं आपस में देखोगे ना बॉक्स पे नीचे आई एम हेलोपेरिडॉल की दे रहे हैं तो ओरल बिकम्स थर्ड लाइन ठीक है ना ओरल थर्ड लाइन का ये प्लीज देख लो because time to peak it shall not be more than maybe a half an hour on average अगर मैं जो हेलोपेरिडॉल इसका अराउंड 15 मिनट्स to 20 मिनट्स में टाइम टू पीक है थोड़ा सा काम कर रहा हूँ हाफ एन आवर अगर आप एजुकेट पेशेंट्स को ऐसे ड्रग देंगे इसका टाइम टू पीक बहुत लेट है दिक्कत क्या है तो प्रॉब्लम एक्चुअली ऐसे कर दे रहे हैं आप इसका टाइम टू पीक इज वेरी वेरी स्लो फॉलो करते हैं आपने आज क्यों से काम करने की दी थी और आपने कहा आपने घंटे बाद पेशेंट आपका फिर क्यों से काम करके प्रॉब्लम ठीक है बताया ही नहीं उसी ड्रग का तो 4 घंटे में आपने 4 टैबलेट दी उनका एक भी पहले टैबलेट पे इफेक्ट नहीं आया शुक्ला प्रिंसिपल अपने जमा डिस्कस It is now available. So when we reserve so broadly क्या strategy होनी चाहिए कि आपके पास अगर ECG monitoring नहीं है तो ECG monitoring नहीं है in this hospital context we are ECG ये ऊपर वाला and other patient is refractory to education कुछ hours हो गए हैं या even so this is repeated then education is not being controlled and it goes we will get it available in the pharmacy so whichever local is needing a fantastic drug Haloperidol is not available एक ओरल डिपो करते थे पहले last year was phased out in the market Haloperidol very good drug oral depot but depots are not supposed to be used for acute because they have their own time to peak levels still a week till days बताओ कुछ कंट्रीब्यूट करो ठीक है so we will discuss the contributions any contribution from the side what's the name hi your name after contribution your comments सब आप लोग अपने करियर में जाके देखेंगे एजुकेशन जब एजुकेशन होगा तो क्या करेंगे वो नीड टू नो ऑल दिस please any contribution from the side fine आपको सबको पढ़ने आना था ना दोस्तों को लगा हुआ है आप बताएं आप बताएं anything turns है one question of contributions or comments और questions आपको कुछ पूछना हो डॉक्टर आयुष से पूछ सकते हैं last two लेंस नाइन से पोस्टल ड्रॉप हो सकता है मॉनिटरिंग करना पड़ता है एजुकेशन में ऑटोमेटिक हाइपर एक्टिविटी रहता है जब हम ये दवाई देते हैं तो ऑटोमेटिक हाइपर एक्टिविटी कम हो जाता है ऑल दीस एंटीसाइकोटिक्स विल कॉज very good symptom access. तो हमें काम इसीलिए एजुकेशन में हमको ये एक्सरसाइज वगैरह a few days before I got a call from PD actually that there is a child with agitation of autism and give exercise. I said, so we want here, this will make him more agitated. Why? Because of can increase the sympathetic tone. Initial few weeks, a few days, and then it creates sympathetic. So बच्चा तो वेट नहीं करेगा sympathetic का and patient might going to see it. The child is slow down and some amount of cloning. ठीक है first stage
How do we decide whether to change the medication?
maybe time to peak levels. Yes. In alcohol withdrawals, there are protocols, things used protocols, symptom-based protocols, available protocols, the withdrawal withdrawal use. तो वहाँ पर तो protocols हैं, साक्षात withdrawal of checking पे अपने सब here they have come up with कि आप इतना वेट करें और वेट करें the hours and then simulating the different wavelengths are different. It can but she was one that we should have. Basically, what we do here is the observe the patient, give an agent, we see the patient as relatively calm down in a matter of I think minutes to hours. Otherwise, we here do not give antipsychotic injections 2-3 times. Then we will do it in the morning, then we do it in the afternoon, and then each one patient for the rather than we used to give the and then we clear the work. This in context of cycles come as a any questions in there? Ask your questions.
Compared to and it was seen that it will good shorter time preservation around 5 minutes.
Actually, I expect for education, and then it is induce those distributive states, which in cutting cycles might make them become maybe agents are sympathetic to version. यहाँ पर आपको लग रहा है कि पेशेंट करना है कि साइकोटिक दिया करेक्टर दिया पेशेंट कुछ थिंक केस में ब्लड प्रेशर इज ओके ऑन द हायर साइड कुछ नहीं इसको कम दो तो सेटिंग्स
John Pierre
was delay and deliver here. So he delay him.
Paul Sharpen.
He delay him. Then start. So basically, number accent we have been utilizing immersion of sleep within previous process. Start education element, education में आप एक्टिव psychology देखें और जहाँ मिनट में जैसे देते हैं वहाँ पे Dr. A should it well. Touch body about this topic. That is how it should be done. Basically, we sync with the moderators, prepare a presentation, add early, and then we do revise it. If you get that, still he is the try to read it, but only the references should be on the slide. Tablet, it will come. तो आपको पता चलेगा कि कैमरा क्यों दिया ठीक है आई स्कोर है 4.5 हो सकता है
There is a patient and variety of fracture. So more than missing the reference for that. So his complaints initially were suggestive of behavior. Presently, sir, is supporting of the police. So it was a true request for him.
ये वही है आपका कैसे हैं क्यों एक साथ देना तो अभी से लिखो क्या पाया क्या है आगे जाकर क्या तो शब्दों में क्या खोया तो ये नशा में फंसे यहीं से ही फ्लाइट बताएंगे वो यहीं से इसको यहीं से ही सीधा एयरपोर्ट भेजना कोई रास्ता नहीं वहां जाकर तो दिक्कत मेडिकल वगैरह अगले महीने